Hello, today we talk about auscultation of the lungs. Previously, we have talked about respiratory system inspection, palpation, and percussion. And by this auscultation, we are finished the examination method of respiratory system. This is our plan today. Uh, Describes the purpose of the lungs, describes the basic anatomy and pathophysiology of the lungs. We will talk about history of auscultation of the lung, how to auscultate lung sounds, about basic landmarks of the anterior and posterior thorax, then how to differentiate normal lung sound versus adventitious sounds, and how to provide possible differentiation diagnosis based on auscultation. This is our lovely lungs. Without it, we cannot breathe, and so we cannot live without these lungs. What they are doing, our lungs? The main function of them are help oxygen from the air we breathe enter the red cells in the blood. Red blood cells then carry oxygen around the body to be used in the cell found in our body. The lungs also help the body to get rid of CO2 gas when we breathe out. They are change our pH of blood, whether the blood is more acid or alkali, by increasing or decreasing the amount of CO2 in the body. Filter our small gas bubbles that may occur in the bloodstream. Convert a chemical in the blood called angiotensin first to angiotensin to chemicals that helps control of blood pressure. Some funny facts about lungs. You know that lungs are not the same size. The right lung is a little wider than the left lungs, but it's also shorter. The right lung is shorter because it has to make room for the liver, and the left lung is narrow because it must make room for the heart. The right lung is divided into three different sections called lobes. The left lung has two lobes. The lobes are made of sponge-like tissues that are surrounded by a membrane called pleura, which separates the lung from the chest wall. Each lung has its own pleura sac. This is why when one lung is punctured, the other can still work. What happens when we are breathe? As we breathe, air travels down the throat and into the trachea. The trachea divides into smaller passages called the bronchial tubes. The bronchial tubes go into each lung. The bronchial tubes branch out into smaller subdivisions throughout each side of the lung. The smallest branches are called bronchioles, and each bronchiole has an air sac, and so called the alveoli. As Department of the Anatomy of the University Göttingen say, there are around 480 million alveoli in human lung. You know that respiratory tract extends from mouth nose to alveoli. Upper airway filters airborne particles, humidified and warmth-inspired gases. Lower airway serves for gas exchange. You can see here this scheme that air go from the nose and it go till alveoli, where is happening the main processes, the purification of the blood. Here, how the blood and the oxygen and CO2 circulated in the blood. That you know that dirty blood are go from right ventricle go to both lung here, left and right lungs. In the lung, in the alveoli, they purified and return it to the left atria in arterialized blood or pure blood and go to the aorta then. How we can do this respiratory exam. At first, we must need a quiet space, proper positioning of the patient. Patient should be in comfortable, relaxed position. Nurse should warm her hands and diaphragm of the stethoscope. Exam should be done on bare skin. Keep in mind, clothes here and other foreign object will make additional sounds while you're listening. And these procedures you know, inspection, palpate, percussion, and now auscultate. It was Hippocrates who discovered the concept of auscultation by placing his ear to the patient just to hear transmitted breath sounds. He describes this as a method of direct auscultation. In 1816, Austrian, no, Laennec was French, um, doctor invented the stethoscope. His first stethoscope consisted of a rolled paper cone. He later utilized a wooden tube. The modern stethoscope had undergone several modifications before being modeled into the current shape. Auscultation is cheap, non-invasive, safe, easy to perform. One of the oldest diagnostic techniques used by healthcare professionals. Technology is great, but it has reduced our bedside assessment skills. Helps in differentiating normal respiratory sound from abnormal ones. For example, crackles, wheezes, and pleural rubs. Need to understand the underlying pathophysiology of various lung sounds to better understand disease processes. Auscultation is a process of listening to the sound of air passing through the tracheobronchial tree and alveolar spaces. Alteration, alteration in airflow and ventilation effort result in distinctive sound within the chest that may indicate pulmonary diseases or dysfunction. So we can see in Paris how the Laennec are listening by via the patient here. Now then he invented this, and we have seen he is listening by wooden tube. This is modern stethoscope. By the way, this is Littmann stethoscope, who seems the most very good stethoscope on the world. Now they are modern in such way that by stethoscope we can not only hear the lung sounds, but record it and to send to other doctors maybe to say his opinion, our friend or our other doctor's opinion about this sound of the lung. The patient should be seated or lying comfortably in a position that allows access to lung fields. Auscultation is done in a systematic side-to-side and cephalocaudal head-to-toe fashion, as in case of the percussion. Breath sounds should always be compared symmetrically. Let's listen first to the left side and then the right side. Sound should be auscultated on the anterior and posterior segments of the chest wall. In full pulmonary examination, the lateral side is auscultated as well. Here is some tips to do auscultation. The first, check the stethoscope to ensure that the diaphragm and bell are locked into the place before auscultating. Some stethoscopes have a rotating bell or diaphragm that may become disengaged, which would block or muffle breath sound. Then, if the patient has a hairy chest or back, lightly deepen the chest and holding the stethoscope firmly against the skin of minimizes crackling noise produced the hair. There's the same scheme as in percussion. So anteriorly, we begin to listen on supraclavicular area and go to ladder-like or zigzag-like here, and go down in each intercostal space, and so we are listening the lateral side of the chest. There is landmark of the infronterior chest wall. The main landmark are sternal line here. This is right medioclavicular line. This is here left medioclavicular line, and on the lateral we have three lines. This is anterior axillary line, medio axillary line, and posterior axillary line, and posteriorly. So we are beginning from suprascapular area here, from the left side, go also ladder-like here, and this is main. We not listening the scapula because it no sense here to listening. Nobody is listening here, and you must know that when auscultated the posterior chest, Well, keep in mind that you will mostly hearing the lower lobes because of the anatomical position of the lobes. So it means that to listen anteriorly and posteriorly, it not means that you are listening the same lobe anteriorly or posteriorly. This anatomical landmark from posterior wall. The central are vertebral line here, and this is scapular line. Physics of the lung. Lung sounds have three major characteristics. It is important for you to understand the physics of the lung, the characteristics of the sound. We have three characteristics: pitch, intensity, and quality, or timbre. Pitch is perceptual quality of sound that depends on frequency of sound wave. Intensity is subjective assessment to determine whether a sound is loud or soft. And quality is differentiated to sound with the same pitch and loudness. As in percussion, here in auscultation, we have also normal and abnormal sound, good or bad sound. Normal sound created by turbulent airflow. In inspiration, air moves to smaller airways hitting walls. There are more turbulence, increasing sound. In expiration, air moves towards the larger airways. Less turbulence and decreased sound. Normal breath sounds are loudest during inspiration and softest during expiration. So we have three normal sounds in auscultation. They are vesicular, bronchial vesicular, and bronchial. Vesicular are low-pitched and heard over the most of normal lungs. Bronchovesicular, medium pitch, heard over mainstream bronchi. And bronchial, or maybe a second tracheal, is high pitch, normally heard over the trachea. There is areas where we can listen this normal sound. Of course, mostly area has vesicular sounds, this orange light here. You can see how many area he has. Second, bronchovesicular, the little blue one, are over the bronchi here. And then around the trachea, we have bronchial or tracheal sound. You know that they are most high pitch on these normal sounds. So vesicular is soft, low-pitched sound. Inspiratory is more than expiratory by duration, and it here over most of lungs. Bronchovesicular is intermediate intensity, intermediate pitch. Inspiratory are equal to expiratory, heard best in first and second intercostal anteriorly and between scapula posteriorly. If heard in any other location, suggestive of consolidation. Tracheal. So tracheal and bronchial maybe have some differences. So let's see these differences. Tracheal are very loud, high-pitched sound. Inspiratory are equal to expiratory sound and heard over the trachea. Bronchial is also loud, but not so loud as tracheal. High-pitched sound. Where expiratory is more than inspiratory sound, here over the manubroof of sternum. If heard in any other location, suggestive of consolidation, so maybe some cancer or something. So now it's better to listen than speak about this sound.
Hey, and in this video, I'm going to let you listen to 3 normal lung sounds. This will be part of a review series of the lungs. I'll be doing a video on abnormal lung sounds as well as a lecture and skills demonstration video as part of this series. So let's get started. Okay, thank you so much for watching. Remember, you can go
To learn it, you must listen, listen, and listen. Without it, you cannot remember it. You learn it by practice, only by practice. Now about the bad and ugly or abnormal sounds. These are called adventitious sounds. They are not normally heard in the lungs. They are caused by moving or colliding with secretion in the tracheobronchial passageways or by popping open or previously depleted airways. Major types are crackles or rals in second name, bronchi, wheezes, stridor, and pleural rub. Crackles. This is discrete, non-musical, non-continuous sound produced by moisture in the lung tissues. Can be fine in quality or coarse. Crackle sound like cellophane being crumpled. Heard more commonly with inspiration as a result of the secretion moving in the airways or closed airways that are rapidly reopening. The main causes of these sounds are pulmonary edema, early cardiac heart failure, asthma, and chronic bronchitis. Let we listen this sound. At first, we heard fine crackles. And now, coarse crackles. So, they we have in pulmonary edema, in early cardiac heart failure, asthma, chronic bronchitis. Now about bronchi. I can say that the generation of the bronchi and these crackles are the same. Crackles are more louder and the bronchi are more low-pitched. Bronchi continuous sound produced by air being forced through narrowed passages. They are similar to wheezes. Bronchi are low-pitched, snoring quality, continuous musical sound. Implied obstruction of large airway by secretion, possible cause acute bronchitis. Now let's listen bronchi. Truly is like of the snoring. Now about wheezes. They are continuous musical sounds produced as air is forced through the narrowed passages, like ronchi can occur in inspiration or expiration. These rals may change characters after coughing. They are high-pitched sounds are usually called wheezes. Low-pitched snoring sounds are usually referred as ronchi. Possible causes are asthma, COPD, and smoking. Let me listen the high-pitched wheezes now. Okay. Then about stridor. This is the sound you will one you hear never forget this. This is loud musical sound of constant pitch, most prominent during inspiration. Can be heard very well at distance due to its loud intensity. No stethoscope needed. Suggest obstructed trachea or larynx. This is medical emergency requiring immediately medical attention. Possible cause inhaled foreign body, and it's mostly we have in children because they like to inhale some foreign body. Now let's listen this stridor. Now pleural rib. Now pleural rub. They are non-musical, sound usually longer and lower pitch than lung crackles. They are discontinuous or maybe sometimes continuous brushing sounds. Occur during inspiration and expiration. Sound like the cracking of old leather, caused by coarsened surface of the normal pleura due to the fibrin deposits thickened or inflamed or with neoplastic cell. Let we listen the pleural rub. Now let we listen all abnormal lung together.
Hey everyone, the 6 abnormal lung sounds, which will include wheezes, stridor, crackles, and pleural friction rub. This will be part of a review series of the lungs. Also, be sure to check out the video on normal lung sounds as well as a lecture and skills demonstration, which is part of this series. So let's get.
So I'd like you to pay attention about continuous of the abnormal sounds because these materials will be in the examination. So continuous sounds are high-pitched wheezes, low-pitched wheezes, and stridor, and discontinuous are coarse crackles, fine crackles, and pleural rib friction rub.
Started. Okay, thank you so much for watching. Remember, you can go to our channel to.
Okay, now I want to watch you the video about bronchophony. The bronchophony is the same as you remember when we have palpation, we have some vocal primitus. There, instead of hand, we use stethoscope here and hearing when the patient are saying something like 99 blue moon. Let me see this.
Bronchophony is the sound that a spoken voice makes when you listen over large airways. Words are louder and clearer than when listening over peripheral airways. When bronchophony is present in an area that is not over one of the main bronchi, it suggests that there is underlying consolidation, as in pneumonia. You can test for it by having the patient say a few words while you listen with the stethoscope. Say 99 or 123. Marvin, when you feel my stethoscope on your back, I'd like you to repeat the words 99. 99, 99, 99, 99, 99, 99, 99, 99.
Okay. My conclusion, the respiratory system is an essential and complicated system with the human body. There are several components of the pulmonary assessment, including inspection, palpation, percussion, and auscultation. Auscultation has become a lot of art and is one assessment that we as school nurses can utilize to evaluate the student's respiratory complaint. Being able to differentiate normal versus adventurous lung sounds is an invaluable skill for the school nurse to process this in academic setting. Having a base knowledge of the anatomy and physiology of the lungs and their external landmarks will enable to school nurse to perform a basic yet helpful assessment when a student has a respiratory complaint. There are plenty of resources on the internet to practice and learn more about lung sounds and how to assess them. And by that, you must not think that is not necessary thing. You may be asked why we learn this auscultation or percussion when we can repair the patient to do some X-ray or some city, some modern city. No, at first it's help you to most now the knowledge of the anatomy and physiology of the respiratory system, and secondly, maybe you we are in such condition there will not, there maybe we have not some X-ray or some echocardiography and CT. So you must now to do the first diagnosis and help. Maybe it is your member of family. Okay, now I'll show you at last a video about a full video about auscultation.
The patient's history determines the scope and intensity of the chest examination. When the history elicits suspicion of the presence of a chest problem, the physical examination of the thorax must be expanded beyond a minimal screening examination to determine the nature of the problem so that a diagnosis can be made. Technique. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. What to observe during auscultation? Breath sounds, vesicular, broncho-vesicular or bronchial, vocal resonance, bronchophony, whispering pectoriloquy, egophony, added sounds, pleural rub, wheezes or crackles. Procedure. Introduce yourself and confirm the patient's identity. Explain what is going to take place and ask for consent. Auscultation of the chest is generally done with the stethoscope diaphragm and is ideally performed in a quiet room with the patient either sitting or standing. Listen to the anterior, lateral, and posterior thorax. Comparing one side to the other is a helpful maneuver to identify the patient's normal. Position the patient's arms over the head to listen to the lateral sides. When the posterior thorax is examined, the patient's arms should be crossed anteriorly to move the scapulus laterally as much as possible. Assess the intensity, normal, increased or decreased, and quality, vesicular, bronchial, or broncho-vesicular of the breath sounds. Vesicular breath sounds are heard on the periphery. Bronchial breath sounds are heard normally over the trachea, the upper sternum, and paraspinal areas of the upper thoracic vertebrae. They are often loud and high-pitched. Vesicular breath sounds. Broncho-vesicular breath sounds.
bronchial breath sounds. By asking the patient to say 99 while ausculting the upper, middle, and lower areas of both lungs on the front and back side. When the sound appears to be near the earpiece or the stethoscope, known as bronchophony, suggests that the sound is traveling through a mass of fluid. Vocal resonance is decreased in pneumothorax and emphysema. It is increased in consolidation. Arise in the pleura and in the lung. Frequently, they're collectively referred to as adventitious breath sounds. Pleural rub. Wheezes. Crackles. Carefully examine the areas that revealed abnormal findings during palpation and percussion. In a dyspnea patient, it is best to auscultate the abnormal areas first, that is, the lung bases, in case the patient becomes fatigued during the examination. Physical findings must be interpreted in the light of all previously collected data. The general scheme is to develop a postural.
Very useful addresses to practice this auscultation. Thank you. By that, we are finished all physical examination of respiratory system. And next lecture, we will have a lecture about respiratory system diseases. Thank you.